Hi everybody, I'm Stacy. I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's talk about language and cultural barriers in hospice and how do we address those. And if you like what you see here, then I ask that you like, subscribe, and follow for more. Well, let's talk about it, cultural and language barriers. As a hospice nurse, I've had many patients that are Spanish speaking only. I do not speak Spanish, so little. I speak so little Spanish, just a few words here and there. And unfortunately, I know how to ask some questions, but if the patient were to answer something complex, I would not know how to understand what the patient was saying. And so it's really important when you have a patient that speaks another language, and there are many other languages besides Spanish, but Spanish is a common example that I use because I've had many patients who are Spanish speaking only. And of course, they always have a family member that speaks English or something like that. But one of the things that I really studied about in my continuing education is the number of people who don't speak Spanish and how we kind of burn out our Spanish speaking nurses because we get an inundation of Spanish speaking patients sometimes, and then we try to put all those patients with those nurses. We have an obligation to provide that care even if we do not speak the same language as our patients. And we have an obligation to provide that care in their language, however that can be. Most hospices have a language line that we use, and I think it's really important to utilize that language line. The thing about using a language line is you want to make sure that you're communicating to your patient and that you're not making them feel disconnected from you as a nurse. One of the things that's been challenging for me with using a language line is that you have a tendency to talk to the person on the phone and then let the person on the phone talk to the patient. But ultimately, I have made it a point to look at the patient when I'm speaking to the translator and look at the patient when the patient is speaking to the translator and the translator is speaking to me, so that the patient understands that I'm interested in how they are feeling and what they are showing me on their face with their motions and with their words. The words are important, but so are the patient's facial expressions, and so are the patient's actions. You can sometimes figure things out without understanding everything about the language by a patient's body language as well. So it's really important when you're using a language line or a translator that you are engaging with your patient still. It's very important that you do that. One of the things that I read in one of the studies that I was reading about for a project that I did for my university was about it was about meeting patients where they are at, and specifically Spanish speaking patients, because they're kind of underserved. But they're not the only ones that are underserved in healthcare. And the reason that they're underserved is because they're not always getting that translator. They're not always getting that person that understands them in their own language. And it's a completely different experience for someone who speaks Spanish and someone who also speaks Spanish in medical terminology and understands medical terminology. Because maybe I could learn Spanish, but maybe I wouldn't understand the medical terminology aspect of it to explain it in the terms that a Spanish-speaking patient would need, for example. Now, I've had other patients who speak, for example, Farsi, or they came from Africa and they don't speak English at all. Or, I've had patients that speak Turkish. I've had patients from many different countries, not in hospice, but in healthcare. And in healthcare in general, you want to make sure that you're meeting your patient where they're at and making sure that they understand what's happening. It has got to be frightening to be speaking to someone who does not speak your language and you can't express to them the pain that you're in, what you're feeling, how your day went, and there's minimal connection because of that. I feel like because of the language barriers, sometimes you're not getting that connection and trust that you would build if you could speak the same language. But it's still just as important to attempt to build that connection despite that. It's very important that when we have patients who speak other languages, that we are meeting their needs and that we are understanding their needs. I can't express the importance of that enough. I think it goes a long way. One of the things that was talked about in the study that I did was how we depend on family members to translate. And because I was in a study and I asked permission to ask my patient's family some questions for an interview for study. I asked that daughter how she felt about translating for her parents. And she said that it was so much easier when a person who spoke her own language was speaking to her about medical things, because although she speaks English, that melding those two things was very difficult for her, and it made it so much easier if she had a person that actually spoke in her own language, her original language, and her father and mother's original language. So that was one of the things. We often expect family members to translate for us, not understanding that sometimes they can't always convey exactly what the patient's saying to us and exactly what we are saying to the patient. So it's very important that when you are using translation, that you offer translation services and don't just assume that the family is going to translate for you. If they want to, I've had patients who just simply do not want to use the translation line. It's uncomfortable for them and they don't want to use it. And I've had patients who say they can speak English and the barrier was evident, so I would open the translation line and just have it open just in case. But I think it's important to offer families that option as well, so that they don't feel obligated to try to communicate those things. Now, having a family member who speaks English to advocate for a patient who is only speaking another language is really important for a patient's care as well. We want people to advocate for their loved ones and be able to say, hey, this is what's happening. This is what my parent, brother, sister, uncle, aunt, mom, dad, this is what they would want, and this is what we are going to fight for. Okay, so it's important to include those family members, but it's also important to help them understand that they are not obliged to be the source of communication between you and the patient. If they want to, or the patient wants that, then absolutely it's valuable to have a family member do that communication. But if they're uncomfortable talking in those terms, it's really important that you do use a translation line and that you do offer that when you're going to a patient's house. It's a guideline. We have to provide patient's own language to them when we are telling them about their disease process, asking them about their symptoms. It's really important that we're communicating those things accurately and in their own language so that they understand, because there's this thing called informed consent. And if a person didn't understand what they were signing or what you said, then it's not informed. So that's my soapbox for that. And then cultural beliefs. You know, when you're working in hospice especially, you will come across people with different religious beliefs that come from different parts of the world. They have different cultural beliefs surrounding death and dying, about how that looks to them, about religious preferences. And it's really important that you have an understanding of your patients as a nurse, of what those cultural needs are going to be at the time of death, what their beliefs are surrounding pain medication in death and dying, what their beliefs are concerning their religion in death and dying. And also in hospice, we have social workers, we have chaplains, and our chaplains are connected with people in the community that understand other religions. They have the ability to bring in a person and connect them to someone in their own faith. Say somebody's here and they are not connected to someone in their own faith, but they have rituals or beliefs that they want to do before they die. Our chaplains can connect them with people who can do that. That is something beautiful about hospice, is that we are trying to meet people where they are at in all cultures and all religions, without prejudice for those things. We want to provide service and care to all people who have a desire to die on their own terms. And what I mean by die on your own terms is not ending your life. When people are coming on hospice, what they're saying is, I am tired of all these medical treatments. I am tired of taking all of these medications. I am tired of going to the doctors. I want to stop doing these aggressive things. I just want my body to do what it's going to do naturally, and I'm not going to intervene. That's what people are saying when they're coming on hospice. Not that they're ready for us to end their life, but that they're ready for their disease process to run its natural course. They want to die a natural death without intervention. They don't want to go to doctors anymore. They don't want needles. They don't want to be poked and prodded on anymore. They're tired and they just want to stay home, enjoy their family, spend their last moments surrounded by the people that they love. And family can look like a lot of different things. And also, when you're talking about culture, it's really important to understand family units. It's really important to understand if a patient would not want a man in their home, if a patient would not be comfortable with a woman providing those cares, if a patient would defer to you speaking to her husband because that's her cultural belief, not because she's oppressed or being disrespected, but because that's her belief. That's her belief system. You know, we have a tendency to come into things that we see differently and make judgments and form opinions about how we should change that for people. But I am a big believer in letting people be themselves and meeting them where they're at. And that is the beautiful thing that hospice does, is that we meet people where they're at in all walks of life, in all cultures, in all religions, in all moments that they're living in. And it is important to understand those dynamics and understand those beliefs so that you can honor those people when they're at their end of their life. It's a short one, but it's an important one. It's very important that we are talking to our patients about what death and dying means to them, how that would look to them, and if there's anything special that we need to know to honor those beliefs. Have you ever had a patient who didn't speak English and you had difficulty communicating with them? How did you resolve that issue? Does your place of work offer a translation line? Do you have other people that translate within your company, within your agency? And have you encountered other cultures and religions? And how did you gain the trust and build rapport with your patients? I would love to hear about it in the comments. Let's talk about it. And if you like what you see here, then I ask that you like, subscribe, and follow for more. And I thank you so much for watching, and I hope to see you soon. Bye-bye.